you get at least these 4 views. You get the axial view, you get a cross-sectional view, you get the panoramic view, and you get a 3D reconstruction. So to plan a case like this, the first thing I do is I go to the pan, I grab an implant, I place the implant. In this case, what I'm interested in on the pan is the angulation and the relationship between this implant and the first bicuspid root. The next thing I do is we use the abutments as future teeth. So it's restorative driven, and in this case it's been decided that this bicuspid, this implant-supported bicuspid, is going to be 7 millimeters mesial to distal. It could be 6, it could be 7.5. You just dial the number in here and you can make it anything you want. So now, by virtue of this abutment contacting the distal of the first bi, and the fact that the implant is centered in the abutment, the spacing, angulation, and relationship between this implant and the first bicuspid is right on the money. The next thing I like to do is duplicate this implant. Now this next tooth is going to be a molar, and again, restorative driven. I now declare that molar to be 10 millimeters. Now if I bring this molar in contact or approximate to the second bicuspid implant abutment, the spacing between these 2 implants will be precise because each implant is centered on the future tooth. If there were a second molar here, the process would be repeated. I would duplicate this, slide it over, and for as many teeth as you have in a row, they will be parallel to each other, and the spacing between them will be right on the money. You don't have to measure the spacing between them. You don't even have to know the spacing between them. It's all based upon the future tooth position. Now the pan is distorted for mesial distal dimension. So basically what I'm getting out of this is an approximation of this position, but I am getting this angulation relationship right here. Sometimes you can have a root that kicks back at an angle, and you want to know that when you're planning your implant. I then might go to the model. Now we've scanned in a model of the arch of interest. And on the model, this is very precise and very accurate. So now I can fine-tune my mesial-distal relationships. When you do implant planning, it's a 3-dimensional exercise, but when you plan it 1 dimension at a time. So right now we're working on mesial-distal. So I can bring this first molar here, second molar here, and I can have an ideal relationship between these implants. Again, what we're trying to do is we're trying to create virtually the same process that one would do on an articulator. Except I think when we do it virtually, I think you have more views and can do it better. Okay, so now we have mesial distal. At this point, I'm going to change the abutment sizes to 1 to use them as center lines. And I'm also going to now bring in a set of articulated models. Now what's nice about the software is that I can then project cross-sections of the articulated models onto the cross-sectional views of the patient's arch. But in the meantime, you still can get a look, as you would if you were using a typodont, to see where the center lines of these implants articulate with the opposing arch. Now, these opposing arch these are hand-articulated models. And another point to make is that we're doing this at the correct vertical dimension. Sometimes individuals will have their patients scanned to show the opposing dentition, and so if the opposing dentition is not at the correct vertical dimension, you may be introducing an error in the angulation of the implant. And one problem with scanning patients with the upper arch, as you see here, is that if there's scatter from the upper teeth, sometimes that can distort some of the anatomy on the lower teeth. Okay, so now we go to the cross-sectional views. So what you have here is you have an left side's buccal. You have an outline of the opposing tooth. So now, when I set up my bicuspid angulation, let me bring in the center line. Not letting me get the center line in the central panel. What I wanted to illustrate was that this implant can be moved buccolingual. And if you picture the center line of this implant up this way, you can manipulate this implant buccolingual so that you can put the center line of the lower bicuspid directly on the lingual cusp of the upper tooth as it should be in an ideal circumstance. And in this particular case, there's plenty of bone, so it allows me to do that. Number 30, the first molar, you can see what you can do. So I can put this right on the lingual cusp. There's plenty of bone, so there's no reason why not to have an ideal occlusal relationship given the anatomy that we have. One nice thing about the software is that, let's say you have a resorbed mandible, and the best you can do is this in terms of implant placement. The software allows you to rotate the abutment and calculates the angle correction. So that's a 19-degree angle correction. So it's very nice to know that ahead of time. And for myself as a periodontist, working with restorative dentists, it's a nice phone call to make to say, I'm doing this case on Mrs. Jones. However, the bone is resorbed on the buccal, and the best I can do is this, and you're going to need a 19-degree angle correction. Are you okay with that? Is this still an implant case? So it's a very nice bit of information to use collaboratively with the restorative dentist if you don't restore it yourself. So now we have the buccolingual dimension set. Again, you can go back and check again to see what the relationships are. At this point, I switch out and I go to a model of the lower arch. I often will put divots in the model before I scan it as a frame of reference. So this divot's 4 millimeters distal from this bi. This divot's 8.5 millimeters distal from the first, so that I can see exactly where I am on the arch. Sometimes virtually, if you have a large rounded arch, you can place the implant beautifully, but you might find the implant to be off-center clinically when you look at it in this fashion. So I like these divots as a frame of reference. And if, in fact, I'm way off, I can go back to see why I'm way off, and then I can see about correcting it. And then finally, well, I'll get rid of this and bring in the patient scan. With the patient scan, you can control the density threshold. So you can make the bone go away but retain the roots. So what I'm showing here is I'm confirming the relationship between, I don't mean to make you dizzy, between this implant and this root. So now, looking at this, I'm convinced that this is a very nice relationship and the distance is appropriate. So, in essence, now we have a plan. This plan would be saved and then submitted to have a guide made.